Welcome to today's custom-tailored deep dive. We've got a truly remarkable mission lined up for you today.
Really do.
Yeah, we are exploring this comprehensive, pretty dense, but honestly incredibly fascinating medical text focused entirely on respiratory assessment and physiology.
It is a massive topic.
Right. And whether you're prepping for an upcoming medical meeting, looking to catch up on your clinical physiology, or, you're just insanely curious about the complex mechanics happening inside your chest every single time you take a breath, you are in the exact right place.
Exactly.
We are going to decode the hidden language of the lungs. By the end of this deep dive, you're going to feel like an absolute insider on pulmonary health.
And what's vital to understand about this source material right off the bat is that we are looking far beyond just the basic mechanics of breathing.
It's not just breathing in and out.
Right. We're exploring the underlying physical laws that dictate why these mechanics matter so deeply in a clinical setting. We'll examine how clinicians learn to spot the incredibly subtle warning signs when these systems start to fail.
And the safety nets, right?
Yes. We'll analyze the brilliant built-in physiological safety mechanisms that are literally working around the clock to keep you oxygenated right now.
Okay, let's unpack this. Think about the simple act of taking a breath. It feels entirely automatic to you, but the journey a single breath takes before it even reaches the lungs is just an engineering marvel.
It's a highly sophisticated system.
Right. Now, we won't spend too much time on the basic anatomy of the nose, but it is worth noting that the upper airway isn't just some passive tube. It's this highly vascular, advanced climate control system.
Climate control is a great way to put it.
Before air even hits your trachea, it's been rapidly humidified and warmed to exactly body temperature, while cilia and mucus are tracking all the foreign particles. But the real destination of this perfectly conditioned air is the lower respiratory tract.
Down into the deep lungs.
Yeah, and I've always found the sheer microscopic scale of the lower lungs kind of difficult to visualize. I mean, how do we conceptualize what's happening at the very end of the airway?
Well, what's fascinating here is the massive expansion of surface area required for effective gas exchange. When that air finally reaches the end of the line, it enters the alveolar structures.
The alveoli.
Right. Your lungs contain approximately 300 million of these microscopic air sacs. To give you a visual, if you were to flatten out the alveolar epithelium, it would cover a surface area of roughly 50 to 100 square meters.
That's huge.
You essentially have half a tennis court of highly permeable membrane packed inside your chest cavity.
Half a tennis court inside your chest. That is wild.
It really is. And within this massive network of alveoli, there are specific cellular workers keeping the whole structure viable. The most critical are the type 2 alveolar cells.
Okay, what do they do?
Well, they only make up about 5% of the alveolar surface area, but they are responsible for synthesizing and secreting surfactant.
Ah, surfactant. When I'm trying to explain surfactant to a patient or a student, I always find it helpful to frame it like a drop of dish soap breaking the surface tension of water.
That's a perfect analogy.
Because the alveoli are lined with fluid, right? So the water molecules naturally want to attract each other, which would cause those microscopic sacs to just collapse completely after every single exhalation.
Yes, and the physics of that are exactly why surfactant is life-sustaining. It intersperses among the water molecules, physically pushing them apart and reducing that surface tension.
So it keeps them open.
Exactly. Without it, the energy required to pry the alveoli open for your next breath would be impossibly high. And alongside those type 2 cells, you have the alveolar macrophages.
The cleanup crew.
Precisely. They are the lungs' dedicated defense force at the cellular level. They're phagocytic, meaning they actively roam the alveolar surface, ingesting microscopic foreign matter, silica, or bacteria that manage to evade the mucociliary escalator in the upper airway.
Okay, so bringing air into that massive half-tennis court surface area requires overcoming certain physical forces. And I've always found the clinical distinction between airway resistance and lung compliance a bit tricky to articulate quickly.
It can be confusing.
Functionally, how do we separate the two when we're actually assessing a patient?
The easiest way to divide them is to think of resistance as a property of the pipes and compliance as a property of the balloon.
Pipes and balloons, I like that.
So airway resistance is determined by the radius of the conducting airways. If you are breathing through a wide, healthy bronchus, resistance is negligible.
Right.
But if bronchial smooth muscle contracts, or if the airway is inflamed and filled with mucus like we see in an acute asthma exacerbation, the radius shrinks.
And it gets harder to breathe.
Yes, according to Poiseuille's law, even a tiny decrease in airway radius causes an exponential increase in resistance. It requires the patient to work significantly harder to pull air through those narrowed pipes.
Got it. And compliance, on the other hand, is about the elasticity and expandability of the lung tissue itself, like the balloon. It's the change in volume for any given change in pressure.
Precisely. And clinically, we see two dangerous extremes regarding compliance. On one end, you have decreased compliance, meaning the lungs have become essentially stiff.
Stiff.
This is the hallmark of acute respiratory distress syndrome, or ARDS. The lung tissue becomes heavy with exudate and fibrosis. Pumping air into stiff, non-compliant lungs requires massive, exhausting pressure from the patient's respiratory muscles.
So that's one extreme. What's the other?
On the opposite end of the spectrum, you have increased compliance. Now, that sounds beneficial, but it's actually devastating.
Too much of a good thing.
Exactly. We see this in emphysema, where the alveolar walls and elastin fibers are destroyed. The lungs become over-distended.
So they inflate too easily.
Right. They inflate very easily because there is no resistance to expansion, but they have completely lost their elastic recoil. They cannot snap back to push the air out, which leads to severe air trapping.
Wow. Okay, here's where it gets really interesting for me. Once that air is drawn in and the oxygen actually crosses the alveolar membrane into the blood, it has to be transported.
The logistics is...
Yeah. Oxygen travels on red blood cells, specifically bound to hemoglobin. We often use the analogy of hemoglobin molecules acting as a fleet of delivery trucks moving oxygen through the vascular highway.
It's a busy highway.
But the loading and unloading of this cargo is governed by the oxyhemoglobin dissociation curve, which has a very distinct, unusual S shape. Why is that?
Well, the sigmoidal shape of that curve represents one of the most elegant evolutionary designs in human physiology. It doesn't follow a simple linear path because of a phenomenon called cooperative binding.
Cooperative binding, how does that work?
Hemoglobin has 4 binding sites for oxygen. When the first oxygen molecule binds, it physically alters the shape of the hemoglobin protein, making it exponentially easier for the second, third, and fourth molecules to bind.
Oh, so it actively accelerates its own loading process as it passes through the oxygen-rich environment of the lungs.
Exactly.
And the flat top of that S-curve, that provides a massive physiological buffer, right?
It does. It guarantees a 15% safety margin for your entire body. Normally, the partial pressure of oxygen in healthy arterial blood is around 100 millimeters of mercury.
Right.
At that point, hemoglobin is almost 100% saturated. Now, if a patient develops a pulmonary disease, or perhaps you ascend to a high altitude, and your arterial oxygen pressure drops from 100 down to 80...
Oh, you might logically expect a proportional drop in oxygen delivery.
Right, but you don't see that. Because of the flat plateau at the top of the curve, the hemoglobin remains roughly 94% saturated. The body actually protects the tissues from hypoxia, despite a significant drop in alveolar oxygen.
That is incredible. And then when those same red blood cells reach the deep peripheral tissues, like say a working skeletal muscle where the oxygen pressure is naturally low, around 40 millimeters of mercury, we hit the steep descending portion of the curve.
Yes, the unloading zone.
The hemoglobin basically loses its affinity for oxygen and readily dumps it exactly where the cellular metabolism needs it most. It's just brilliant.
It really is.
But that delivery system is entirely dependent on the physical act of ventilation. So how does the body automatically calculate when to speed up or slow down the respiratory rate to match that metabolic demand?
The neurologic control of ventilation operates through a multi-layered feedback loop. The primary command centers are situated in the brainstem, specifically within the medulla oblongata and the pons.
Okay, the brainstem.
And these centers do not rely on conscious thought at all. They dictate the rate and depth of breathing by continuously processing data from various sensory receptors throughout the body.
The primary drivers being the central chemoreceptors, which are looking for chemical triggers. But they aren't actually monitoring oxygen levels, are they?
Not primarily, no. It's a common misconception. The central chemoreceptors in the medulla are exquisitely sensitive to the pH level and the partial pressure of carbon dioxide in the cerebrospinal fluid.
Carbon dioxide, not oxygen.
Right. Carbon dioxide readily crosses the blood-brain barrier. When CO2 levels in the blood rise, it forms carbonic acid, which drops the pH. The brain instantly detects the acidic shift and fires signals to the diaphragm and intercostal muscles to increase the rate and depth of ventilation.
So you start breathing faster to essentially blow off the excess carbon dioxide and restore the acid-base balance.
Precisely.
All right, so beyond the chemical monitoring, the source text highlights mechanical triggers that act as physical fail-safes too. The Herring-Breuer reflex is a prime example of this.
Yes, the stretch receptors.
Right. There are stretch receptors embedded directly in the smooth muscle of the airways and alveoli. When a massive inhalation distends the lung tissue to a certain point, these mechanoreceptors send an inhibitory signal up the vagus nerve that literally halts inspiration.
It cuts it off.
Yeah, it's an automatic physical override preventing your lungs from overinflating and suffering barotrauma, basically keeping you from popping your own lungs.
Which is very important. And we have to consider how these finely tuned chemical and mechanical systems change over time. When looking at this from a gerontologic perspective, structural changes begin to manifest surprisingly early.
Really? How early?
Starting around age 50, the alveoli begin to gradually lose their elasticity. Concurrently, the volume of physiological dead space, which are areas in the respiratory tract where air flows but no capillary gas exchange occurs, begins to increase.
Which naturally leads to a progressive decrease in overall oxygen diffusion capacity. The source also notes that the physical strength of your respiratory muscles peaks in your early 20s before beginning a slow, steady decline.
Yes.
But I want to point out the clinical takeaway here is actually reassuring. For you listening, it's important to note that despite these measurable gerontologic changes, an older adult without an underlying chronic disease typically handles daily activities without any respiratory compromise.
Exactly.
The changes usually only become apparent as a decreased reserve capacity during vigorous exercise or acute illness.
And that decreased reserve is exactly why clinical assessment becomes so critical when things do go wrong. Clinicians have to act as detectives, relying heavily on a meticulously gathered patient history.
Right.
Even taking a symptom as common as a cough requires nuanced investigation. A cough is rarely just a cough.
Right. The specific characteristics of the cough tell a distinct story. Like, if a patient presents with a chronic, dry, irritating cough, it might not be a pulmonary issue at all.
Not at all.
It's frequently a side effect of ACE inhibitor medications used to treat hypertension. ACE inhibitors prevent the breakdown of bradykinin, which then accumulates in the respiratory tract and chemically irritates the airways.
Very common.
Or, if a patient complains of coughing primarily when lying flat at night, the structural gravity points strongly toward postnasal drip from the sinus cavities. But if they're producing profuse, frothy, pink-tinged sputum, well, that shifts the diagnosis towards something critically severe.
Yes, like a pulmonary tumor or pulmonary edema, where elevated capillary hydrostatic pressure is forcing fluid and red blood cells into the alveoli.
The presence of blood in the sputum is always a critical juncture in the assessment. And a classic clinical dilemma the test points out is distinguishing between hemoptysis and hematemesis.
Those sound so similar.
They do. Hemoptysis is the expectoration of blood from the respiratory tract, whereas hematemesis is the vomiting of blood originating from the gastrointestinal tract.
Right, and the presentation gives us clear diagnostic clues. Blood originating from the lungs is typically bright red and frothy because it is actively mixed with air and surfactant.
Okay.
Furthermore, if tested, it presents with an alkaline pH. But blood originating from the stomach is visually distinct. It's often much darker, frequently described as resembling dark coffee grounds because it's been partially digested by gastric acids.
And then it predictably has an acidic pH.
Exactly.
Those subtle historical clues guide the entire physical exam. But patient history also involves lifestyle and environmental exposures, which brings us to a pervasive modern clinical issue: the use of ENDS, or electronic nicotine delivery systems.
Commonly known as vaping.
Right. There is still a lingering public perception that e-cigarettes serve as a harmless alternative to traditional combustible tobacco. What does the source material say?
Well, the clinical data and empirical findings from the FDA contradict that perception entirely.
Yeah.
The source text makes it clear these are not safe alternatives.
Right.
E-cigarettes utilize heating elements that aerosolize liquid containing multiple volatile and potentially toxic substances. One highly concerning chemical highlighted in the literature is acrolein.
Acrolein.
Yes. Acrolein is an intense chemical irritant that is actually utilized in agricultural settings as a potent weed killer.
A weed killer. Wow.
Yes. When inhaled deeply into the human airway, it denatures proteins and causes severe acute inflammation of the lung parenchyma. The data definitively links this exposure to acute lung injury, the acceleration of chronic obstructive pulmonary disease, and severe asthma exacerbations.
So we know vaping is a modern environmental risk that patients actively choose to take. But what about the risks patients don't choose? What does the source data say about demographic or systemic risks when evaluating a patient's overarching pulmonary health?
If we connect this to the bigger picture, the epidemiological data reveals stark realities regarding systemic vulnerabilities. We are just looking at what the source notes here, imparting the data directly.
Right, strictly by the numbers.
Exactly. The source notes that African American men demonstrate a 37% higher incidence rate of developing lung cancer compared to Caucasian men, even when their statistical smoking rates are entirely comparable.
That's a significant disparity.
It is. Furthermore, marginalized demographic groups and populations living below the poverty threshold experience disproportionately higher rates of severe asthma exacerbations. This is coupled with significantly lower rates of receiving essential prophylactic care, such as the influenza and pneumococcal vaccines.
It perfectly illustrates that respiratory health cannot be evaluated in a vacuum. It's an intersection of genetics, individual environment, and broader demographic factors.
Absolutely.
So, transitioning from the history to the physical assessment, what happens when the clinician finally gets hands-on with the patient? Visual inspection is the first step, but the text highlights a major misconception here regarding cyanosis.
Yes, it is a vital clinical myth to bust. Many people intuitively associate a bluish tint to the skin or mucosal membranes cyanosis as an early primary indicator of hypoxia.
That's what you always see in movies.
Right. But in physiological reality, cyanosis is a very late and highly unreliable sign of inadequate oxygenation.
Oh, really?
Yes. The physical manifestation of that blue color requires a specific absolute concentration of unoxygenated hemoglobin circulating in the capillary beds, usually around 5 grams per deciliter. Therefore, a patient suffering from severe anemia could be experiencing dangerous cellular hypoxia, but they will rarely exhibit cyanosis simply because they lack the total hemoglobin volume required to visibly turn the tissue blue.
That makes total sense.
Conversely, a patient with polycythemia, which is an abnormal excess of red blood cells, might visually appear cyanotic, even when their arterial oxygen saturation is well within perfectly healthy limits.
So you can't just trust your eyes on that. But a far more reliable visual marker of chronic long-term hypoxia is the clubbing of the fingers, right?
Yes, clubbing.
Where the nail beds lose their normal 160-degree angle and become sort of spongy and bulbous. Clinicians are also visually assessing the overarching configuration of the chest wall.
The shape of the chest itself.
Yeah. Chronic respiratory diseases fundamentally alter the skeletal structure over time. A patient with severe emphysema frequently develops a barrel chest.
Due to the air trapping.
Exactly, because their lungs have lost their elastic recoil and are chronically hyperinflated with trapped air, the anterior-posterior diameter of the rib cage actually expands outward until the chest is essentially as deep as it is wide.
Once the visual inspection is complete, clinicians utilize palpation to assess the underlying tissue dynamics, specifically testing for tactile fremitus.
Tactile fremitus.
The clinician places the ulnar edge of their hands firmly against the patient's posterior chest wall and instructs the patient to repeat a resonant phrase, commonly 99.
99.
Yes. The clinician is physically feeling for the transmission of vocal vibrations traveling down through the bronchial tree and across the lung parenchyma.
And this relies entirely on the basic physics of sound transmission. Solid mediums conduct sound waves far more effectively than gaseous mediums.
Right.
So if a patient is suffering from lobar pneumonia, a significant portion of their lung tissue has become consolidated, meaning it's filled with fluid, exudate, and inflammatory cells. That dense, solid area will conduct the vocal vibrations much more intensely to the clinician's hand.
Presenting as increased tactile fremitus.
Right. The clinician will also percuss, or tap, on the chest wall. Striking over healthy, air-filled lung tissue produces a normal, resonant sound. But percussing directly over that dense, fluid-filled pneumonia consolidation yields a flat, dull thud, kind of similar to percussing over the liver.
And the inverse is true for the emphysematous patient. Because their lungs are hyperinflated and heavily saturated with trapped air, containing very little dense structural tissue, the vocal vibrations of 99 are severely dampened.
So you get decreased or absent tactile fremitus?
Correct. And when percussing that overinflated chest, the clinician will hear a hyperresonant sound, functioning acoustically like a hollow drum.
Which brings us to auscultation, the use of the stethoscope. Listening to lung sounds is basically an exercise in acoustic pattern recognition. We're listening for the smooth flow of normal vesicular breath sounds, but we are aggressively hunting for adventitious or abnormal
The
sounds.
crackles and wheezes.
Yeah, the two primary categories. Crackles are discontinuous, explosive popping sounds. They occur when air is forced through accumulated fluid in the airways, or when collapse, sticky alveoli suddenly snap open during inspiration.
And wheezes are different.
Wheezes are entirely different. They're continuous, musical, high-pitched tones. They're generated when airflow is forced through conducting airways that have been severely narrowed by bronchospasm, mucosal edema, or a foreign body.
But the most profound diagnostic use of the stethoscope actually involves testing for abnormal voice sounds, specifically a phenomenon known as egophony.
This part blew my mind.
It's fascinating. If a clinician auscultates a suspicious area, they will ask the patient to continuously vocalize the long vowel sound E. Over healthy lung tissue, the stethoscope picks up a muffled, indistinct E sound.
Right.
However, if there is a fluid consolidation, the increased density of that fluid fundamentally alters the acoustic wave. As the sound travels through the fluid, the clinician clearly hears the letter A instead of E.
So the fluid consolidation is essentially acting as an acoustic filter, absorbing the higher frequencies and changing the harmonic wave of the sound before it even reaches the stethoscope.
Yes.
That is just a brilliant application of physics to bedside diagnostics.
It is. And the exact same acoustic principle applies to whispered pectoriloquy. Normally, a whispered word is completely filtered out by the air in the lungs and is inaudible through a stethoscope.
You hear nothing.
Right. But over a dense consolidation, the high-frequency whisper is transmitted perfectly, sounding abnormally loud and distinct directly through the chest wall.
So what does this all mean for modern technological assessment? Because while the physical exam is foundational, we obviously now rely heavily on continuous digital monitoring.
You.
The pulse oximeter is ubiquitous in every clinical setting, utilizing light wavelengths to continuously measure peripheral oxygen saturation. But the text explicitly notes it has significant blind spots.
It does.
It can provide completely inaccurate readings if the patient has poor peripheral perfusion due to cold hands or hypotension. It's also skewed by external factors like dark nail polish or deep skin pigmentation. And most importantly, a pulse oximeter only measures oxygenation. It tells you absolutely nothing about how effectively the patient is actually clearing carbon dioxide.
Which is why the integration of capnography, or end-tidal CO2 monitoring, has become the gold standard in critical care. While pulse oximetry measures the oxygen bound to hemoglobin, capnography measures the precise concentration of carbon dioxide at the very end of the patient's exhalation.
Okay, so it gives you the ventilation status.
Exactly. Utilizing specialized infrared sensors or chemical colorimetric paper, it provides instant, breath-by-breath waveform data. It is the definitive method for confirming endotracheal tube placement. Well, if a breathing tube is accidentally placed into the esophagus instead of the trachea, there will be zero carbon dioxide exchange. The capnography waveform will flatline, and the colorimetric paper will fail to transition from purple to yellow. This instantly alerts the clinician to the catastrophic error.
That is so crucial. And when the clinical picture remains unclear even after that, we transition to advanced imaging modalities. CT scans provide high-resolution cross-sectional mapping of the pulmonary vasculature and parenchyma.
Yes.
MRI technology is utilized to evaluate soft tissue tumors, though the source does emphasize a strict safety protocol regarding the massive magnetic fields. Patients have to be screened for implanted metallic devices, and even transdermal medication patches like nicotine patches must be removed.
Yes, the foil backing.
Right. The microscopic metallic foil backing can superheat in the MRI, causing severe localized burns. We also utilize VQ scans, using radioactive isotopes to map ventilation against pulmonary perfusion to identify mismatches like a pulmonary embolism.
And, of course, bronchoscopy.
Yeah, bronchoscopy allows the clinician to advance a flexible fiber optic camera directly into the bronchial tree to actually visualize the mucosa, extract foreign bodies, or biopsy suspicious lesions.
We have an incredible array of diagnostic tools at our disposal today, but utilizing them effectively always circles back to a deep, fundamental understanding of the foundational physiology we discussed at the start.
It really does. We have taken a massive journey today, mapping the respiratory system from the microscopic architecture of 300 million alveoli, riding the hemoglobin delivery trucks through the vasculature, right up to the macroscopic physics of a physical exam and the high-tech imaging of modern medicine. Thank you so much for joining us on this custom-tailored deep dive into your own physiology.
The true value of exploring this dense material is how you choose to apply it. Recognizing these physiological principles, whether it's understanding the biomechanics behind an older relative's barrel chest, comprehending the precise inflammatory mechanisms of why e-cigarettes damage tissue, or simply knowing why a clinician is percussing your back and asking you to say 99, it transforms you into a highly informed, proactive advocate for your own health and the health of those around you.
I completely agree. Now, to wrap things up, I want to leave you with one final, unaddressed thought to mull over. Given how exquisitely sensitive our brain's internal chemoreceptors are to minor fluctuations in carbon dioxide, and considering how our mechanoreceptors physically guard the expansion of our alveoli, it makes you wonder. As wearable medical technology becomes increasingly sophisticated, could we soon be wearing smart clothing embedded with acoustic sensors that constantly measure our tactile fremitus and chest excursion, capable of alerting us to microscopic lung consolidations days before we ever feel that very first tickle of a cough? It's something fascinating to think about. Until next time, keep questioning and keep exploring.